how it's changed our hospital practice, and perhaps then have a consideration of how this may change things further moving into the recovery phase. So apologies to those who've heard me talk before. Some of the material will be familiar to you, but this is not Sophie and I at a fancy dress party. These are two historical figures in medicine, and as is often the case, you can learn a lot from looking back when you're thinking about first principles looking forward, and these two characters will come up later in what we have to say. So you may cast your mind back to the earliest stages, essentially breaking it down into the simplest forms. There were the concerns about containing the virus, then delaying the virus, and then essentially mitigating its effect. What it doesn't mention is stage 5, which is recovery. And that's where we are now, and there is as much uncertainty in the recovery phase as there is in the preparation phase. Research is ongoing, clearly at a global level. I will show you a little bit of the data that's coming through, what appears to be right, what appears to be wrong, and what we've learned along the way. So some basic virology, you'll be pleased to know that it is basic. The coronavirus, or SARS-CoV-2 to give it its formal name, abbreviated to COVID-19. It comes from a families of single-sense RNA, and when we track its taxonomy, it's closest linked to bat and pangolin sequences, and it is possible that it has jumped from those across to the human population. And essentially, it does show some overlap with the original SARS in 2009, MERS, the Middle Eastern respiratory virus, and essentially it accesses the human cell through the angiotensin converting enzyme type 2 receptor protein via these spike proteins that the virus shows on itself. And when you look at this under the electron microscope, they sort of show up like a crown, and hence its name. So with the focus now on testing, the concept of what do you measure is quite relevant to when you may find virus in the patient. And this is highly relevant to us as practitioners working in potential aerosol generating procedures. Because we know that from the time of infection to the time of symptoms can be quite variable. The viral load then goes up, the patient is infectious, and it takes a while for the body's immune system to kick in and create an antibody response. So your antigen test will pick up the virus quite early. Your antibody test will not pick it up directly, only your body's response. Quite what that means in regards to whether you are protected or not is still unclear. And indeed, with the modern concepts in the laboratory about PCR, polymerase chain reaction, you can pick up really tiny fragments of the viral code. The question is that in the longer tail of release of the virus, does that mean that the patient is still infectious? And we are certainly seeing patients who've had classic symptoms, have been detected as PCR positive, are continuing to be PCR positive long after their symptoms have resolved. What we don't know is whether that reflects ongoing infectivity. So when we look at the virus itself, it's not just a single entity. There are over 300 mutations that have yet been characterized by genome study of it in the global setting, with 3 principal subgroups. And in the next slide, I'll show you a little bit of how those have tracked across the world. So viruses, they just want to survive. They're very simple things, and of course, to evade the immune response, they will continue to mutate as they are created in vast numbers in each patient. So when we look at the tracking of these through molecular techniques, we can make the families of them, we can track them worldwide, and this will hopefully inform not only the disease monitoring process, but also formation of a vaccine, which obviously will need to cover as many of these as possible. So I'm going to just switch at this point to the internet and to play this video. So please bear with me while I shuffle things around. 1 second. Richard, you may have to just let me know that you are still seeing what I'm meant to be showing you. Here we go. So I'm hoping now you'll see a map of the world, and on that you should see a picture of the viral spread and those various clones that are now emitting from the China epicenter. And you'll see that the first clone is colored purple, and if I scroll up here a little bit, we can see where we are in the phylogeny map. So here is the timeline along the bottom, and here the first clones were essentially purple colored. This is the type A virus, and you can see it's spreading from its epicenter in China, both east and west across to the States, but interestingly, and down south towards Australia. Interestingly now, it's coming up as a red center. All right, sorry, I think let me just pause that for a second. Apologies for the technical issues. If that's not going to work, I will talk our way through it. Richard, you may have to help me here. If you're online, can you unmute yourself?
Hi, Jonathan. Yeah,
hi.
I'm just sending you a picture of what I'm seeing, so you can see what I'm seeing.
Let me move that one out of the way. Okay.
So that
right. Every time you come to Zoom, it shows you something different. Right. Hopefully now you should see a map with many colors.
Yes.
Yes?
Yes.
Hooray. Right. Apologies for that. Let me go back a little bit. So essentially from the epicenter of our start, we are seeing spread from China in this central here blue taxonomy region, and how it has moved south into Australia, both east and west. And essentially, as it's moved in a westerly direction, the clones that have been created in Europe are from a different strain to that in China. And you can see by the color coding that the strains in America are also a different nature. And if we just play the video now, this will kind of play through things as essentially we can track this virus by genomic analysis of the different strains and of how it has moved globally, and with some reverse investigative work, you can identify certain airlines and planes. You might have seen that in the news of potentially how you can see these early sort of tendrils stretching out to Iran. And again, the response in Iran and the response in China has not always been entirely accurate. And of course, there's no hiding in the world these days. And Iran may say, well, we don't have any cases. And then you might question why your satellites are picking up enormous great burial grounds being built outside their central cities. So now as time moves on, you'll see how the phylogeny of the virus is changing. So we don't really understand at the moment what the different disease profiles mean. Does each strain of the virus mean a different clinical picture, a predisposition to different patients, there is still a lot of work to be moved through in order to have a better understanding of this. I'm just going to flick to a couple of other videos while we don't have to wrestle with the technology too much. So we are going to talk a little bit about sneezing and why we have the social distancing. So we will come back to this, but forgive me for doing it in continuity rather than fight with technology too many times. So this is a time lapse high frequency photograph of a sneeze, and essentially that's the projectile pattern of the droplets that will come out in the explosive sneeze pattern. And we'll talk about why that's important for us, particularly in the context of aerosol. So sneezes are one thing, coughing is another, and here again we can see through a slightly different technique the dissemination of the aerosol through a natural coughing process, and how the velocities of the exhaled aerosol are obviously less than a sneeze, but they do get up to 8 to 10 meters per second. So you have this large cloud of aerosol that's being released and potentially influencing the environment around you. Right, let me plot again to go back to where we were, hopefully with a little bit more right. One day I'll get good at this, but that day is still to come. Right, so moving on. Coughs and sneezes spread diseases. Well, we all learnt that in the playground. It's true. We do have to remember, though, that in the pollen season is coming, so not every sneeze is COVID, but obviously there is a concern with regards to protecting ourselves and others in the aerosol dissemination of the virus. So we all have had drummed into us the 2-meter rule of we should be socially distanced. Well, where do we derive that figure from? So essentially, we've just looked at a couple of videos of the aerosol generation here of the sneeze reaching 50 meters per second. And essentially, you're going to blow these large spray droplets out to a distance of up to 6 meters. So this is why we need to catch a sneeze. Ideally not in our hands for reasons I'll explain, but in some form of retardant method. Coughing, that's essentially then providing an aerosol. So your aerosol is a much smaller particle size, and these, because they're not projected at such a speed, will tend to fall and be limited within a 2-meter radius. And that's essentially why we have this concept of 2 meters of social distancing. Now, what you'll notice is that gravity will take certainly the larger droplets, and these will fall to the ground and essentially then sit on any surface called viral fomites. And although the virus is actually very small, it is relatively tough, and it has been demonstrated to survive on metal and plastic surfaces for really quite some time. And this is the rationale that essentially takes us back to hand hygiene. If you touch something, then bring it up to your mouth, because the portal of entry is in the respiratory and oral epithelium, then that is the conduit of viral transmission. So when we talk about masks and gloves and things like that, it is not just the protective equipment, it is what you do with it. And I will come back to that when we talk about PPE in a bit more detail. So, moving on. So we've looked at the anatomy of a cough and these speed diagrams of the air coming out. We've looked at the anatomy of the sneeze. Now, essentially, when we're thinking about the transmission of this, the concern that we have is that not all patients get symptoms, and you may be infectious even if you do develop symptoms in a short period of time prior to that. And the median times for the onset of symptoms is 5 days, and the onset of infectivity is 3 days. Now, essentially in the early stages, what we were unable to determine because of the data that was at that time available is that we didn't know where on the exponential curve we were going and which way we were heading. So essentially, depending on which country you were in, there were very different exponential curves predicted with regards to how the disease would play out, what the patient numbers would be, because essentially COVID will spread if it's unchecked to a large number of patients. Now, you can characterize that in a virus by this so-called R0 number. So the bigger the number is essentially how many other people a single person with the disease will infect. So measles is very high, it's highly contagious. Influenza, much lower. COVID, actually, we don't know. It's probably between 3 and 5, but because of the methods of social distancing and disease control, we need to keep that under 1. If you keep it under 1, then the viral prevalence will go down. If it tips over 1, then it will go up. It is literally as simple as that. So the difficulty is that we don't have ethically the ability to put patients into a sealed chamber, give 1 or 2 of them the disease, and then watch it play out. Happily or unhappily for some, this has already been done for us. So you may cast your mind back to the Diamond Princess cruise ship that set off from China and moored outside Japan at the beginning of February, and there were proven coronavirus patients on that ship. Now, that has actually informed epidemiologists about the behavior of the virus in a confined population. So there were 3,700 passengers on that ship, of which over 700 eventually tested positive for the virus. And it was then essentially calculated that 18% of them demonstrated no symptoms at all despite testing positive. And essentially from that data, we can determine, what is the likelihood of patients in front of us demonstrating symptoms. And also you can calculate what is the fatality rate, which again has varied widely. If you look at the WHO, they will quote you 3.8%. Probably on the basis of this ship, if you take symptomatic patients, it's 1.1%. And if you take in asymptomatic patients through calculation and modeling, it's probably 0.5%. So, that doesn't sound like a big number, but actually it does mean that potentially 0.5% of patients infected with this virus will die from it. So, after that, those dark statistics, we can then think a little bit about how can we track the epidemiology of things. So if we now look at the UK data, we can try and determine some of the influences of the social distancing and quarantine measures that we've had. The difficulty has been, for reasons I've just explained, that without robust testing in large volume, in large numbers, then essentially you're having to use proxy markers to determine how well your effects are actually being affected. What manipulations are you doing and how well are they working, with the lag that actually it takes a while to spread the virus, incubate the virus, demonstrate symptoms, go to hospital, go to ITU, and or dies. So each one of those markers becomes later and later in the disease progression. So here we can see the timeline from the UK. This is when we went into lockdown. We were still on the upslope. We didn't know whether it was exponential, linear, or whether it would plateau. It has plateaued and it's tipped down very well. And that's essentially where we are at the moment. If this is a graph that we've been following in our own ITU from the Northwest London region, and you can see that we were very tightly on the upslope here. It's now plateaued off, and here we can certainly see reduced numbers of COVID positive patients in our ITUs at present. Now, the next thing to comment on is that this disease appears to be different things in different people. We understand that there are certain risk groups. We understand that there are background features, not all of which are fully understood. But again, through Public Health England, we've looked at ward patients, and essentially the take-home message from these graphs is that the older you are, the higher up you are on the graph. So young people at the bottom, older people at the top. And you can see that for non-ITU ward patients, there's a very significant increase in your admission rate the older that you get, and it has a significant male slant. If you look at the graph on your right, your ITU patients, again, a massive slant towards the male sex. Interestingly, less 70+ patients on the intensive care unit. That is multifactorial, but it is a consideration. Particularly, doctors have had to make some very difficult decisions about whether it's appropriate to escalate treatments in patients with other known or unknown health comorbidities. Now, this is a season, so you can actually then extrapolate the mortality rates. Rather than measuring it directly, the Office of National Statistics will have the death rates per month, per year, over the last few years. And essentially, there is the winter peak, which is usually related to influenza. And here you can see the influenza subtype and these sort of speed bumps of mortality that occur over time. In the far right-hand side, essentially what you're seeing as this trajectory completely takes off is where coronavirus has massively increased the observed number of deaths out of all proportion to the expected number of deaths. And that is probably a more realistic marker of the effect of the virus. And when I say effect of the virus, there is obviously the number of patients that it has infected itself. But what we also are starting to understand is the indirect effect of the virus. Patients are not coming to hospital with conditions that we would normally expect to see at certain frequencies. They may be diabetic complications, heart attacks, strokes, other issues. So that is clearly still going on. And one of the indirect mortality figures of coronavirus is how much of that is happening in the background for patients that are not actually wanting or able to come to hospital. So at this point, what the challenge for the health service was in the very early stages of things was to try and project how we would get through the possibility of a very wide pandemic and the worry that this would potentially overwhelm the resources that we have. So I'm going to play a short video which I think helps to put this into perspective, but please remember that this was made prior to the quarantine, prior to the pandemic really kicking in the UK. And in that regard, it is something that is still valid now, but it's interesting to reflect back upon the predictions that it made. Now, it does have a soundtrack. I have put the subtitles on. I will do my best to play the soundtrack, but again, just bear with me. But so essentially what he has described was whether we were ever going to have the capacity in that exponential phase of the virus, of whether we would be able to cope. And it was essentially making that bottle bigger that was the driver to create these field hospitals such as the Nightingale and things like that, to be able to process patients through the system in a way that we could cope, avoiding the scenes from Lombardy where essentially patients would come into the hospital and being turned away. So this is the situation that we face now. So there was some debate at the beginning of, did we quarantine in time? Why should we, shouldn't we, etc., etc. We did. We stopped the flow. We filled up the bucket. We got to the point that actually hospitals probably only had another 24 hours of acute admissions before they would have to close. It went very close. Now we had the bucket, the bottle is starting to empty. But the worry is when we release the lockdown, and obviously lots of people are looking to Sunday to see what's going to be announced politically. What they don't want to happen is that the bottle then fills up again and overflows in the kind of second surge. So the government's decision originally was based on how could they project that they would fill up the bottle enough, not overfill it, but not underfill it. And essentially, the bottle creaked at the seams a bit, but it managed. And it managed without spilling over to the Nightingale Hospital, which had just about come online at the appropriate time. So what he was predicting then was one period of quarantine to try and lock down the population for as short a period of time because of the predicted resistance, pushback, backlash. No one quite knew how everyone was going to take it. Actually, they seem to have taken it very well. There's probably been a bit of softening. There's been very nice weather. People have been out and about. But actually, epidemiologically, you know, things have not overflowed. So I think that poses the dilemma that we have now. We need to get back to work. We need to address, you know, the unmet healthcare needs of the population, the business, the economy, all of these things. But what we cannot afford is for the bucket to overflow again. And I think that is a difficult projection to have. Because of how people will take another lockdown. Oh, sorry. So I'm going to just swap back to the slide. So hopefully now we can talk a little bit about the clinical situation. So what we know is that there's an asymptomatic cohort of patients. And what we know is that there are patients who go to hospital who are shown to have COVID. And when we look at the hospital situation, we can see that many of them have fever, debilitating fatigue, a kind of dry cough, they lose their appetite, significant muscle-related discomfort. They lose their sense of taste and smell, and they are often breathless. Now, how predictive those symptoms are in the general population is not as clear. If you look at the UK recommendations, there are principally 2 symptoms. If you look at the WHO characteristics, they're 11 to 13. And these may well become more important for us as we potentially screen patients coming to our practices for features that they may have the virus at any one time. And this is work in evolution. So essentially, if you pitch up to hospital, you will go through, they will find out whether you have these symptoms. You'll have some imaging of your chest, some blood tests to look for what your blood cells, your white cells are doing, what inflammatory markers are there, and whether there are pictures where your blood has become very sticky. And in some patients, they have a very significant coagulopathy, so they will be getting pulmonary emboli and other particularly significant clotting abnormalities which have caused a really significant challenge for their ITU management. So they may have fancy scans, they're at risk of secondary infection. And I think Sophie's now joined us from ITU. So because she has a good handle on the clinical pattern of things, and she's also been on the wards acting up or acting down as one of the junior doctors as well, I think I will defer to her personal experience of all of this. Sophie, can you hear us? Richard?
Yes, so Sophie's now should be with us. Oh, good. Okay, great. I'll unmute myself.
Can everyone hear me?
Yes, thank you. Welcome.
Oh, Thank you. Sorry to miss the beginning of the talk. So yes, sorry if I've repeated as well what Jonathan's already gone through, and I think he's talked about the kind of clinical features. So as mentioned, the kind of median day for symptoms to start after being exposed to the virus is about 5 days, but can extend up to 11 to 14 days, which is why that 14 days is often chosen for when people need to self-isolate, for example, when arriving into a new country. We've already talked about the fact that we don't know what the R number is exactly. Certainly within in a hospital setting, it does seem to be very infectious. We've had nosocomial cases. We've had many members of staff who have been off sick with the virus. And also what we don't know is that once you've recovered, how full is that protection from your next infection? If you've had a very mild form of the disease, even if you've got to IgG levels, is that going to protect you from another infection? So many unknowns. But once symptoms start, the main risk period for deterioration is about day 7 to 10. And this is the main time when we see people coming into hospital, often with worsening hypoxia, ongoing fevers, and very raised inflammatory markers. Estimated that about 80% have mild disease, about 14% have severe disease needing hospital admission, with 5% of these needing critical care. And the overall mortality rate estimated at 2.3%. I think that's still an estimate at the moment. Risk factors for severe disease, certainly we see in our group of patients, one of the main ones is age, and you see this well demonstrated on the next slide, but also underlying comorbidities, ischemic heart disease, diabetes, and we've seen a very high mortality amongst our renal dialysis patients as well, up to about 15%. Underlying malignancy, also immunosuppression, being overweight with a BMI of 40 has been a risk factor for severe disease, and also makes it very difficult for our ITU team to be able to look after these patients on ITU, and male sex is another risk factor. So just some examples of images, so just some typical chest x-rays here. So one of the typical findings that we see on a chest x-ray is kind of bilateral infiltrates, and I've just shown a slice of a kind of fairly typical CT from one of our patients as well, which also shows interstitial changes. Okay, so treatment-wise, so mainly at the moment it's supportive care. We used to aim for SATs over 94, but we've brought that level down and now aim for SATs of 90 to 94% supplementary oxygen, starting off with nasal cannula, moving quite quickly if patient needs additional support to Venturi masks. Some patients will then require further support, and what we first might do is ask them to prone. So even do self-proning on the ward can up their SATs level and work quite well. Some patients might need CPAP. About 20% of these patients who need CPAP then avoid needing an ITU admission, but 80% will still need to go to ITU, where they are nearly always ventilated. And some patients even require ECMO, although we've referred some of our patients, some of them have been accepted. Other complications, we see about 40% needing renal replacement therapy, so that is significant. Some people recover, but up to about 20% still ongoing renal replacement need when they leave ITU. We've seen patients with myocarditis, even ones with heart failure, and we've seen an increased level of confusion and delirium, particularly when patients then step down from ITU setting to the ward and worried about a viral encephalopathy effect. Many of our patients are being placed in trials. We've got a number of different trials running, which is just for our ITU patients at the moment, some with specific antivirals such as remdesivir, and early trial data from remdesivir is looking very promising. It's uncontrolled data, but it does look to be showing a mortality benefit. On the other hand, a trial with Kaletra did not show a benefit, but the drug was added in quite late into the patient's clinical history. Steroids have been used particularly for patients who've developed ARDS, and also some promising data for tocilizumab, particularly patients who have a kind of cytokine storm or a very high inflammatory response to the disease, and hydrochloroquine is being looked at as well. There was some early promising data from France, but this was uncontrolled and now being reviewed. This really needs to be looked at in a controlled trial setting. Self-care at home, so the advice is to stay well hydrated. I think, as Jonathan's mentioned, there seems to be a thrombotic effect of the virus, so we always recommend that people, even if they're feeling rubbish, which often they are, and often they will literally just feel like not getting out of bed at all, but it is important, like on an aeroplane, to kind of keep moving and keep all muscles to try protect against the thrombus. Paracetamol is probably recommended for bringing fever down and helping to feel a bit more comfortable. There was a concern about ibuprofen, but again, not borne out by evidence, so that's still under review. And I think people should, if they really feel they're not getting better, they really should seek help. We're concerned that the stay-at-home message maybe has meant that people are too cautious about seeking help. They're too worried about coming to a hospital setting for fear of getting infected. But really, we want to reiterate that if you're struggling with your breathing, you really should come and get reviewed, because we need to measure oxygen sats, do bloods and a chest x-ray. It's been quite useful. We've recommended for people at home to use a pulse oximeter on their phone. And although it's not proven, it does seem to have been helpful for people and reassuring. But again, we'd recommend that you seek hospital help if for ongoing fevers or struggling with breathing. So, for example, getting out of breath, just going up a flight of stairs, or not able to complete full sentences when speaking. So I'll pass back to Jonathan now. Thank you.
I think, thank you. I think essentially we've moved through the phases of the virus, the exponential growth that then became linear, plateaued, and we're on the downslope. We've maintained social distancing, and we've explained a little bit of the science behind that. We're in the lockdown and everyone's looking for quarantine release. The big concern from a population perspective is whether that would then initiate a second surge or a super surge, and the worry that that would overwhelm capacity. Even though we're probably a bit smarter at organizing ourselves now, we still have the surge capacity, although interestingly the London Nightingale Hospital has been essentially mothballed on a temporary basis. And the social impact of repeat quarantine is obviously going to be quite considerable, both at an individual and an economic level. So essentially, I think in the final part, we're going to talk a little bit about our personal perspectives of how things have changed. Sophie perhaps will talk a little bit first about her experience at the Royal Free from the medicine / infectious diseases point of view, and then I will finish off.
So I think, as Jonathan's probably mentioned earlier on, I'm very lucky to work with a really excellent infectious diseases team who, and from the very beginning of the concern about the pandemic hitting England, we were a designated surge hospital. And so we looked after many of the first positive patients. And fortunately, at the beginning, many of the patients had mild disease, but we soon started to see, as the numbers increased, we soon started to see people with severe disease. And I think quite early on, we realised the possible devastating effects that this could have for patients. And we did an early and very large reconfiguration of the rota, involving all the medical teams, bringing back many surgical colleagues, and kind of sent everything into a kind of 3-day off, 3 nights on a 12-hour shift period. And we're now able to kind of come back from that more slowly, as it really is very tiring and very exhausting for doctors to continue to work at that level. All elective work was cancelled, elective surgery was cancelled, clinics all had to be reviewed, all the patients had to be reviewed to see whether they needed urgent reviews, and we've been able to continue clinics at a certain level, but on the whole we've been trying to do it by telephone, because we don't want patients to be put at risk by coming into a hospital setting, where really about a month or so ago we had a very high level of coronavirus transmission, and I expect we had quite a significant environmental contamination with the virus as well. I've been involved quite a bit in looking at kind of infection control for our renal dialysis patients, who again, unfortunately, have been hit very hard by significant numbers and a significant mortality amongst these patients with coronavirus. And we've been trying to do lots of training surrounding personal protective equipment. And I think so many doctors and nurses have become unwell and sick. It's given many people a lot of anxiety that the PPE, although in our hospital we have enough, that maybe the level of it is not sufficient, because we have different levels for ITU and for ward-based care. And what we're also really concerned about is, where are all the patients that we used to look after in our hospital? We're really worried that they are now at home, too worried to come to hospital. But we really want to see them back so that we can get them the right treatment as well. For example, this week we must have admitted kind of four or five patients with ascending urinary tract infections, and our concern is, were they sitting at home with kind of more simple lower urinary tract symptoms that we could have got treated? So that's an ongoing worry for us in infection.
And I think probably something to add there, you know, the worry from the dental community will be the same, that there are people perhaps sitting on symptomatic or asymptomatic orofacial conditions that actually, you know, would warrant treatment need, but are either too anxious to access care or are unable to access the urgent centres in a safe and efficient way. So we mentioned a little bit about the Nightingale Hospital, and obviously the lady that we showed you at the beginning is Florence Nightingale. Not only did she talk about infection prevention, bed distancing, but she also was very assiduous in her note keeping. And essentially the aim of infection control, infection prevention, is going back to those very simple historical precedents that were laid down so early. Nightingale has been replicated across the country as the kind of surge and super surge capacity. It's currently not being used, but the emphasis is that it can be used, and they have been commissioned and they are still commissioning them. The next question is, what will they do with them? That's as yet uncertain. So PPE. So Sophie, you can describe this level of PPE.
So here, I mean, this is our kind of our top level of PPE. So here's a picture of our infectious diseases matron, and this is for the high consequence infectious diseases, for example, Ebola, where patients are looked after within a tent on our high security infection unit, and you can see the full level of PPE with gloves and a mask, and patients are looked after through care through the tent. So we're not at that level of PPE. This is a completely different virus because it's a respiratory virus.
So the sort of thing that we are and have been using, and this is what I would be using to place tracheostomy tubes in ventilated COVID patients on intensive care. The main thing is essentially your basic protection, double gloving, eye protection, and an FFP3 mask with adequate protection of the surrounding skin. Clearly, to ensure that your FFP3 mask fits, you have to undergo a fit test, and that's a requirement for whether it's FFP2 or FFP3. We are seeing probably about 25% of our staff who were fit tested failed their first fit test. So it is not sufficient to just hand someone a mask, put it on and expect it to fit. If you need this a level of protection against aerosolized virus. So by the time you've got all of that on, you look like this, which is quite uncomfortable. You get rather hot. but you do get used to it. And essentially, when we are talking to our trainees about how to put it on, you need to ensure ideally that the aerosol is reduced. So you're doing it in a controlled setting. There may be things of high volume suction that can be helpful in the dental setting, a rubber dam, but essentially to protect yourself against aerosolized virus, you want to think about a small child standing in front of you with a can of spray paint that they are going to try and spray it on you. They're not allowed to move from the front, but they are trying to get it onto your skin, and you're trying to protect yourself against that. Now, PPE will come in different shapes and sizes, and essentially, instead of full or non-full, the best thing to concentrate on is whether you're going to be in an aerosol generating environment or not. And that obviously then has implications in the dental setting of who is going to be in a room with an aerosol and who is not. And there are some good guidelines in pictorial format. Careful consideration has been put forward for this. What is the best protection? But obviously at the start of the epidemic, there was a paucity of the equipment in some cases, and the paucity of the ability to test the equipment. So in that regard, maybe things were pressed into service a little earlier. There was maybe an over anxiety. People were not getting feeling that they were getting all the correct PPE, but it's there. There are guidelines with regards to what should be used, what are the requirements, what is the best practice to protect yourself essentially from infection from your patients. There are videos. I know that the whole concept of PPE is one that's very familiar in the dental setting, but maybe not in a way of actually how to put it on to completely protect yourself, and more importantly, how to take it off, the so-called doffing procedure. And I think this is a photograph of the front of the Sunday Times magazine, which I happened to buy at the weekend. This was a photojournalist who'd spent some time in our sister hospital at the West Middlesex, and it shows, the level of PPE. So they had the kit, and they were very well protected. But what this photograph also shows is that you can have all of the kit, but actually, if you put your hand that has been in an infected environment up to your face, or you're not wearing eye protection, then actually it doesn't matter what you're wearing, the risk of transmission increases significantly. So it's not just what PPE you have, it's how you wear it, and importantly, how you take it off. Because if you're a climber, you may be aware that most climbing accidents occur on the way down from the mountain. On the way up, you're focused, you've got a goal, you have to do it. On the way down, you slightly switch off. And it is probably the case that many of the episodes of healthcare workers infected while wearing PPE have occurred in the doffing, taking off process. This is a very ritualized taking it off, because if you think of that child standing in front of you, spraying you with the paint, actually you've got to take that paint covered kit off without the paint getting on you. And actually there is a bit of a technique to that about how you can minimize that risk. And if you cut the corners or forget it, then believe you me, when you've had that on for an hour, you just want to take it off as fast as possible. But it's important that those levels of details, they will become, the new normal. So how long till we go back to normal? This is a question that I have often been asked, and then disappointingly, I'm not going to be able to give you an answer, because I think we are understanding the concept of the new normal. Will we go back? Well, we will go forward, I think, rather than go back. And I think it is important upon us to understand that there will be some significant differences in where we go in the outgoing landscape. So essentially, I think we can look at this at a national level, at government, how we are going to work out the logistics of PPE, procurement, delivery, training, ensuring that you and your staff are confident that you can protect yourselves and you can protect your patients. So essentially, there will be national guidance that will come out. It will be evolving. It's guidance. It's important. But it doesn't tell you exactly how to implement it. So you can understand that there may be social distancing required in your practice, but the actual implementation of that will have to be taken at an individual practice level. There isn't a one-size-fits-all recipe. So in that regard, a lot of it will be, how do I get the PPE? How do I ensure that it's appropriately used, that we can be efficient with it, effective with it, we're not overusing it, but at the same time, we're not underusing it. We are going to have to think about the way that we work. If we are fixed on repeating how we worked pre-COVID, then that's the wrong expectation. Essentially, we need to rethink the structures of how we work, not only clinically, but I guess also financially, and how that's going to work for us at an individual level. And again, it's not only running through things when it goes smoothly. We did a lot of simulation training on our surgical procedures so that we got slick at it before we actually touched a live patient. And we do have a bit of time now to think about those things. Do walkthroughs of your practice. Can you maintain social distancing? Because essentially that you are as only far apart as the closest point that you are to someone. So if you're 2 meters apart, but there's one place that you absolutely are going to find yourself falling over each other, then you've got to find a workaround for that. What happens if a patient turns up with a fever? How are you going to identify that and deal with it? And it's worth thinking through that in advance so that you're not sort of scrabbling around at the time. Patients, well, patients, our patients will have concerns. They will have concerns about their safety. Are they going to get it from you? Are they going to get it from others? Are they going to get it on the way there? So what their concerns and worries will be quite different perhaps to oh, Sophie's having a chat, will be quite different to what your staff are worried about. So they will also be concerned about the travel aspect of things, the distancing in and out of the practice. Will they have the opportunity to run through things? What are effective patient screening? So we're going to be thinking about in the hospital doing a lot of telephone triage, risk assessments, again, but knowing that it's not a perfect science. There are going to be asymptomatic patients. There are going to be pre-infectious patients. So again, the perspectives, it's a difficult one to get your head around, but I think that it is incumbent upon us to try and work through each of those episodes at an individual level and understand as individuals what level of risk we are comfortable at. We've come from an environment of risk aversity and blame, a bit of a blame culture, and actually that I think that mindset is going to take a while to change. So do I have the answers of what happens going forward? No. Have I explained a bit of the science and the clinical side of COVID? Yes, but I probably said in many times, and Sophie too, we don't know. And that dealing with uncertainty is probably one of the major features of what happens going forward. I wonder if you recognize the guy on the right of your screen. This is a chap called Ignaz Semmelweis. He was the first to document the importance of hand washing in preventing the spread of infection. And he worked it out then actually a simple cleaning of your hands would reduce the infection spread. His ideas were so heretical at the time that actually the intelligentsia locked him up in a psychiatric hospital. He died in a psychiatric hospital because of his theories were so radical. Of course, we realized that actually now with an infectious agent that we don't have good drug treatments for, we've got to go back to basics. And it is really important to learn from these perspectives that we're all in it together. I guess the final thing I would like to say, perhaps before we go into questions and answers, is I would invite all practitioners and all practice principals to be very active in this. It's quite easy to step back, say, oh, they're going to tell us what to do, they're going to tell us this, tell us that. That doesn't mean rush into things, but I think, there is going to be, a certain requirement to be quite proactive in the recovery phase, because I think it's going to take a long time. And the new normal will look very different to the old normal, so to speak. So that's it of the Collier COVID summary of where we are. It'd be very interesting to know where we're going. But Sophie and I are both online. Richard, if you perhaps found that there were questions that you felt it would be helpful for us to answer now to the best of our ability. Otherwise, I would like to thank everyone for listening and for their attention. And I hope that you stay safe. I hope you stay well. Please wash your hands. And I think, Sophie and I are just able to share our personal experiences of this, but I do think that it's something that will become important in that interpretation of things moving forward. So, thank you.
Jonathan and Sophie, thank you both so much for giving up your time to speak to Alpha Omega this evening. It's really much appreciated, and to have your expertise on this minefield really, and a period of uncertainty is really it's wonderful, valuable, and we really thank you so much. I'd like to just announce to everyone here, if you have any questions, please add it on the chat group so that I can see them and read them out. I have one already, Jonathan and Sophie, if it's okay if I read one out to you.
Sure.
It was, please could you confirm the viral load from a cough or a sneeze will be more than aerosol generating procedures from dental water lines which have antimicrobial cleansing solutions in to stop biofilm formation. So I think differences between sneezes and coughs versus dental aerosols.
So I think the viral load depends on the patient, and it depends on the stage of infectivity. There's been a lot of concern that some of the early spread to health practitioners occurred predominantly in patients who were very close to the practitioners. So dentistry was one, ear, nose and throat surgery, to a lesser degree ophthalmology, and that's what the global data has demonstrated. So undoubtedly, if you have a active virus sitting in your oropharynx, nasopharynx, and you are generating an aerosol from that. Now you can do that by talking, particularly talking loudly, breathing, more so coughing and sneezing. And essentially that's just projecting it forward. Now, what's not yet known is that if you induce an aerosol in those patients, so this is not the aerosol that comes from the dental handpiece, the scaler. This is essentially what's hitting the oropharyngeal secretions and then essentially aerosolizing them. So you are not going to get reservoirs of virus in your water lines, but as soon as they are blown over a surface that can potentially pick them up, that is the time that we are worried that aerosols will be dangerous.
Thank you. I had a couple of other questions, a few questions on the same thing really, but would it seem that antigen to date are not sensitive enough for some people? And do you have any idea when these tests are going to be available?
Do you mean antigen tests or antibodies? Antibody tests?
One was antigen test and the other one's antibody. So
okay, so I mean, antigen test, I think there's a couple of things about sensitivity. So the swab needs to be done properly, which actually means pushing it quite far back into the nasopharynx. So that's a concern about some of the kind of test kits that are sent to people at home. Are they going to do them correctly? And then we do see sensitivity kind of increasing with more than one test done. What we also see in patients with severe disease is that sometimes they are antigen negative in the upper respiratory tract. So say, for example, if you do a nasopharyngeal aspirate, but positive in lower respiratory samples, so if you send a sputum. And we've been thrown off track by that a couple of times. But I think that will be less relevant for people in the patients in the community. So sensitivity-wise, reasonable, I think, in a well-taken swab. The antibody test, that really does need more work and to know where the right setting is to use it. There are so many different kits. And many have had to be kind of rushed to market, often kind of tests on only a few people. It looks like IgM can be quite helpful in increasing sensitivity with the PCR or the antigen test if done together. But really, we haven't quite worked out how useful IgG antibody testing will be, and also if it is positive, what level of immunity that carries. So I think there's still quite a bit of work to be done on that.
Thank you. One other question we have here is, are we treating non-COVID patients with regular PPE or is our routine PPE a thing of the past for dentists?
So at the moment, the recommendation, while we have a high level of transmission within the community, would be to use regular PPE for all patients within our hospital setting. I'm not aware of what it is within a dental setting, but I think it would be very reasonable to do the same thing. And I think that was on Jonathan's slides. Jonathan, if you could confirm that. So I think that would be a surgical mask for review of patients.
So I think, I mean, interestingly, the kind of immediate response from organisations such as the British Association of Oral and Maxillofacial Surgery, our ENT colleagues, mainly those who were still having a clinical workload. In a way, the kind of the dentistry aspect of things just got shut off at source. But actually, if you look at what the recommendations are for dentists in the urgent care, dental care settings, and for all of us doing any procedure in the mouth, the initial guidelines were for aerosol level PPE. So that was an FFP3 mask, visor, long-sleeved impermeable apron, and double gloves.
And now, that would be for all patients.
Yeah, so that was the same. Mm-hmm. That was basically because, so you have to remember that actually what they didn't want was 16 sets of kind of PPE guidance. It was kind of small, medium, and large. You know, you're either in or you're out. Now, having done that, how easy it is to step down from that is more difficult, because clearly a simple dental examination with no obvious use of let's say the 3-in-1 and that sort of thing, actually the risk of aerosolization from that is very, very small. And if you look at some of the reports of dental practice around the world, undoubtedly you will find people doing dental checkups with just let's say pre-COVID PPE, so a face visor or eye protection and a standard surgical mask. It is going, the time scale of sort of stepping back from the full PPE thing is going to be a difficult one. And I think there will always be a default to having the best level of protection. And I think, again, that comes back to where individuals, will reflect upon their own particular pattern of risk management. Personally, I would want to feel that I am fully protected when doing something that may potentially expose myself or my staff to the virus. And in that regard, it's then about the logistical constraints of having enough of the PPE. So now we're talking about sessional use of PPE, whether you're using a mask and then an over mask. So I think there are ways around that. But the current guidelines, which I think will take a while to step down, is certainly been along the lines of aerosol level PPE with a fit tested FFP3 mask.
Thank you both. Another question here. Do we have any data on number of dental teams who have been confirmed or hospitalized with COVID-19, either nationally or internationally? And if I could add a little bit to that, is the risk at the dental practice, but also coming home from the dental practice in terms of within the community? Where does the risk lay, and what precautions do you feel we need to take when going home as well?
So dentists have not been included in the healthcare worker statistics that have been highly published from the UK. Undoubtedly, there have been incidences of dental care professionals contracting the virus. I know of a few patients in our hospital who've had it, who are dentists. Now, whether they got it from dentistry or not, we will not be able to determine, because it is unclear whether they may have been exposed to that in the work setting or in the external environment. And I think actually, if you do your infection control mechanisms carefully, and you are able to don your PPE, you have the appropriate level, you doff it, then actually probably in real terms, your risk of catching the virus will be greater outside of the dental environment than inside the dental environment. And I think just one more thing. So I don't know what the government will say about masks, wearing masks on public transport. Now, they're not talking about FFP3 masks. They'll be talking about surgical masks or make your own masks. Now, if you go back to the anatomy of the cough and the anatomy of the sneeze, those masks are to prevent you spreading it to other people. They do not protect you getting it from other people. We need to be clear about that. And the other side issue of the mask is that it is something on your face. And whenever you have something on your face, you have a tendency to fiddle with it. So in some ways, unless you are very careful, it can be counterproductive, because all of a sudden your hands, which have touched surfaces on the viral fomites, are now up around your face, fiddling with the strings, adjusting the nose, this, that, and the other. And in that regard, there are far greater opportunities to self-infect yourself with a mask. So the science behind it is obviously a little bit more complicated.
I'm sorry, I've got to go, but I just wanted to chip in and answer just a couple of other questions that I can see on the group chat before I go. So there's one question about how come the spread to Africa is so minimal. Now, I'm not very knowledgeable in this area, but I was talking to one of our infectious diseases doctor who's worked quite a lot in Africa and was there for the Ebola outbreak. And she says that they've been very, very militant with their quarantine. As soon as anyone comes into a country, they're quarantined for 14 days. And I wonder if that's been beneficial for them. And also I wonder, there might be some issues around testing. Just to kind of move on perhaps to the next question, which is about changing will we need to change gown and the gloves and masks? So in the hospital setting, we only use PPE for a sessional use when we know that all the patients are positive, so that we're not concerned about spreading the risk from patient to patient. But you will be working with patients that you might know are positive. Most of your patients you won't know the status of, and so therefore I think that they will need to be changed after every patient. And is there any logic to testing staff in surgeries before they resume work? Certainly if they have symptoms, I would agree with testing, and then following PHE guidance about when it's safe to come back to work. I think testing asymptomatic staff is something we've been looking at in the hospital, and I think it's unlikely that we will do it. I think the main thing to reiterate to staff, even if, because a lot of people feel under pressure to kind of come to work, they want to do their job, they want to help patients, is that they really shouldn't be at work if they have symptoms. And I think that's probably more important to reiterate to lots of staff than necessarily doing testing asymptomatic people. So focusing on testing symptomatic staff would be my recommendation. And I'm sorry, I've got to disappear off.
Not at all. I think that's a good time. Basically, thank you everyone so much for joining us. If there are any further questions, I can email them on.
No, I think that would be fine. I mean, I do fully understand that Sophie and I have worked in a very privileged position where we've had access to a number of things and resources which are not necessarily freely available, and actually access to a number of information sources that are freely available and not freely available, or are diluted out by a lot of misinformation. So, I do feel that we have an ability and an opportunity to try and help our clinical colleagues really, and sort of rehabilitate in that regard, and help to define where we should go. And I think, as I said, it's important to be proactive. And there will be some things that we will take forward that will hopefully help practitioners to actually steer their way through this difficult territory of things that are known, things that are not known, things that have a risk, and actually trying to provide practical solutions for people to take things forward in a sensible way.
Perfect. Thank you both so much. I'd like to just announce to everyone now, watch out for Alpha Omega are releasing a letter, a document, and it should be published with FMC website soon. So hopefully by the end of this week, there should be an announcement in FMC Dentistry Magazine on the website first, and then in print later on. So keep an eye out for that. Yes, everyone keep safe, stay well, and look forward to seeing you at many more Alpha Omega events in the future. Thank you very, very much.